So
স্যার এই স্লাইডগুলো গতকালকে দেখিয়েছেন অবশ্য বেশ
হ্যাঁ,
কিছুতে।
আমরা দ্রুত চলে যাব, তারপরে যেগুলো হয়নি ওখান থেকে আমরা যাব।
জি
So
স্যার।
we will be covering these topics during today's class, and yeah, we already talked about these things yesterday. Just to recap these things. Now come to the definition. What is MCH? It refers to the promotive, preventive, curative, and rehabilitative healthcare for mothers and children. Components: so mother's health, and then the child's health, the school health, adolescent health, family planning, handicapped children, care of the children in special settings such as daycare centers. Objective: reduction of the maternal, perinatal, infant, and childhood mortality and morbidity. Promotion of the reproductive health, promotion of the physical and psychological development of the child and adolescent within the family. Now you can see we wrote here reproductive health. We didn't write here mother's health, or we didn't write child health or MCH. We wrote reproductive health. Where does this term come from? So there is a question. And sometimes some teachers in your exam hall might ask questions on these things. Okay. 1990 সালে মেইনলি প্রথম, তারপরে 1994 সালে দ্বিতীয়, but 1990 was the first time when people took initiative to provide mother's health care in a safety manner. Before that, even in Bangladesh and also outside the world, the health service for mothers and the children were given as a separate component. So health for the mothers and then health for the children. So two separate components were being delivered or were being provided. Okay. But then when gradually the scientists or the clinicians or the healthcare providers, they understood that, oh, this mother health and child health is very much related. So when they understood, then they started to adopt the initiative. If the mother is good, if the mother is safe, the child should be safe. So the child health is dependent upon the mother's health. So in 1990, in Kenya, Nairobi, there was a program, ICPD, International Conference on Population and Development, ICPD. And in that program, for the first time, the scientists all together, they have talked about the safe motherhood. And then the safe motherhood project was being taken. And after that, gradually, it has evolved that, yes, we should be talking about as a unique component, not a separate mother's health or not a separate child health issue. And then all together, they termed as reproductive health. So this term was within the practice of healthcare service providing people since 1990. Before that, the term was there because reproduction is every time related with mother, but out of reproduction, a baby is born. So, and the society continues in this way. We have to, we didn't actually address this issue as a unit of reproductive health, but from 1990, we have started using this. Okay, so we need to know a little. So that's the initiative. When sometimes it's in the Viva hall, sometimes the teachers ask, okay, when was the safe motherhood initiative taken? So it's in 1990 in Kenya, Nairobi. And in 2000, they again convened. But in 2010, they again sat together. And at that time, the conference name was ICPD Plus. That means we have to think something more added. And then ICPD Plus, probably it was held in Kobe. Kobe means in Japan. Okay, you will not find these things in the books, in the textbooks. So because I was involved. Ji walaikum assalam.
স্যার ওই যে বলেন আইসিপিডি এই কনফারেন্সটা 1990 তে কোথায় হয়েছিল?
Kenya, Nairobi.
থ্যাংক ইউ স্যার।
হ্যাঁ, মোস্ট ওয়েলকাম। আর 2010 যেটা হয়েছে, that was termed as ICPD plus. That means they wanted to talk more, they wanted to learn more about this reproductive health and safe motherhood initiative, and they wanted to know the experience from different countries, so they convened together in Kobe, in Japan, 2010. Okay, so that's why we have to be very careful about this term or terminology, reproductive health. And if you go with the book of Rashid Kabir Haider, you will find there are 8 components of reproductive health. So please, I'm referring to those Rashid Kabir Haider and the reproductive health components, because sometimes some teachers, they only ask, okay, what are the 8 components? You don't need to tell in detail, but you have to tell at least the names. যে এই 8টা কম্পোনেন্ট কি কি আছে। Probably প্রথমে হচ্ছে safe motherhood initiative, তারপরে probably adolescent health care, then intranatal care, antenatal care, intranatal care, postnatal care, then safe motherhood initiative, adolescent health care, তারপরে antenatal care, postnatal care, intranatal care, 5টা গেল। তারপরে হচ্ছে care of the newborn, তারপরে হচ্ছে care of the STDs and AIDS, because these are very important diseases during the reproductive health if they are affected by these. আমি 7টা মনে করতে পারছি, আর I cannot remember the 8th one. Just have a look from the book of Rashid Kabir Haider, okay? Because এই 8টা components, sometimes the teachers, they might ask অন্য আর কোনো কিছু হয়তো নাও জিজ্ঞেস করতে পারে, so you don't have to worry about it. But out of those 8 components, maybe some teachers may take only one component and then they tell, okay, just describe this component or describe the importance or the activities of antenatal care. Okay, যে কোনো একটা পয়েন্ট নিয়ে, কম্পোনেন্ট নিয়ে টিচাররা হয়তো জিজ্ঞেস করতে পারেন। So please go through the book Rashid Kabir Haider and just make notes of those 8 components. Okay. What are the problems in our country? One is malnutrition, another is infection, and another is uncontrolled reproduction. Whatever, I have some reservation of some terminologies, but yeah, because we are being governed by the first world, as we are a member of third world. That's why whatever they say, we have to say. And that is the thing I'm trying to do. I'm trying to develop our own standard so that we can talk from ourselves. We don't need to have any source of recommendations from the outside world. But for the time being, we have nothing to do. Okay. So what happens on the account of malnutrition? So for the mother, the maternal depletion, low birth weight, anemia, toxemia, and postpartum hemorrhage. For the children, the low birth weight followed by the infections, then marasmus, kwashiorkor. It's related with the waning time. Now the infections, the torch infections. So from the UTI also, the low birth weight occurs, IUGR, embryopathy, abortion, and puerperal sepsis. For the children, they are suffering from diarrhea, respiratory, and skin infection. Okay. The uncontrolled reproduction, this causes increased prevalence of low birth weight, severe anemia, abortion, and antepartum hemorrhage. The maternity cycle starts from fertilization, and then the antenatal period, intranatal period, postnatal period, and interconceptional period. We should remember some terms. what is embryo, what is fetus, what is premature, what is full term. Probably yesterday I was talking what is infant and what is neonate. So infant is up to 28, infant is up to 1 year. Neonate is only the first 28 days, okay? So these two terms, you can add it in this slide. Antenatal period is the care of the mother during the conception period. And then the mother and child, we have to think as one unit, because the children or the child is getting oxygen and other nutrients from the mother during the antenatal period, during the conception. And then the child health is closely related to the mother's health, because if the mother is affected, the child should be affected. Certain diseases and conditions, I already talked. What is this? This drug, you see. This is the problem. Okay. During the antenatal period, the child gets oxygen and nutrition, and certain diseases and conditions. So if the mother is suffering from these 4 diseases, the toxoplasma, rubella, cytomegalo, and herpes, the children will suffer. And also some drugs, and we have to be very careful that some drugs, even the vitamin B complex, should not be given in the first trimester of pregnancy, though it's a vitamin, because there are no supportive studies that vitamins is helpful in the first trimester, but there are risks of giving vitamin in the first trimester. So this is very, very important thing. In our country, you will find many doctors, they prescribe. First trimester, you cannot give anthelmintic drug even. So mother is suffering from helminthiasis, you cannot give, because it will lead to malformation of the child. So that's we call teratogenic effect. So we cannot really go for these things in the first trimester of life. So every woman, every lady who will be visiting a doctor should take note whether the mother is pregnant or not, and then he should prescribe the drug. After birth, exclusive breastfeeding, mental and social development, and also mother is the first teacher of the child. So you see, this is so closely related. That's why the scientists have come to decision that yes, we need to take into consideration that the mother and child health should be taken into one unit. And these discussions, it came in 1990 in Kenya, Nairobi. What is antenatal care? It's during the conception period. The objective is to promote, protect, and maintain health of the mother, and also to detect the high risk. And after detecting, we have to provide the necessary support to them. And then we have to observe and monitor the progress to understand what types of complications the mother can face, and then how we can really prevent those problems. And because pregnancy is a physiological condition, but it's related to so many problems. So this time is a time of anxiety and stress. So also the doctors should be careful, or the healthcare providers should be careful to remove the stress and anxiety, and then the conditions associated with it up to the time of delivery and also after delivery. And then to reduce the maternal and infant mortality and morbidity. To teach the mothers about the child care, nutrition, personal hygiene, environmental sanitation, to sensitize the mother to the need of the family planning, to attend the under 5 accompanying mother. Antenatal visit, we talked about this also. Ideal visit is 14, recommended by WHO. Minimum visit is 4, again recommended by WHO for those third world countries or the developing countries who really cannot afford these the cost and also the time for those 14 visits. But in the advanced world, 14 visits are common. It's just mandatory, and all the mothers, they go for it. In Bangladesh, it was 3, but now we have at least developed a little. Now it is 4. What are the 14 visits? So the first month, and then in the first to seventh month, once a month, and then the 8th month is twice a month, and then thereafter once a week. So this is how we constitute the 14 visits. And minimum 4 visits, it is first is as soon as possible or by the 16th week. And then the second visit is at 32 weeks, third visit 36, and fourth visit at the time of expected date of delivery. And then what happens there, we do register and we do take a history. And if the mother is not being given TT, we give the TT laboratory examination. And also we need to know when we should administer the TT, the 2 doses. So it will fall in the second trimester, not in the first trimester. Risk approach to identify the high risk mother and arrange for the support for them. And then we need to know who are the high risk mothers. Who are the high risk mothers? Elderly preemie, short statured preemie, mother with malpresentation, antepartum hemorrhage, toxemia of the pregnancy, that is preeclampsia, anemia, and then if there are twin pregnancy, the hydramnios, prolonged pregnancy, that is 14 days after the EDD. So these are all high risk mothers. What is antepartum hemorrhage? So anytime during the conception, if the mother complains of bleeding, so during the pregnancy or during the delivery, we call it antepartum hemorrhage. And this is a very important, this is danger sign. Immediately the mother should consult the doctor. Hydramnios is also another condition, and it should be diagnosed by ultrasonogram. And then whenever it is diagnosed, we should immediately consult the clinician. History of previous stillbirth, IUD, intrauterine death, manual removal of the placenta, and history of cesarean section or instrumental delivery, pregnancy with the comorbidities. So these are all important. What are the danger signs of pregnancy? If you remember the 5 danger signs, it's enough for you. And what are the 5 danger signs? I have given you in your biostatistics lecture. So in the pie chart, so the pie chart, there are 5 things. Those 5 things are 5 danger signs. And every time all over the Bangladesh from 1994, I guess, 1992, there was an organization, BARPART. It is still, I think it is there, but it is not, the activity is not that much pronounced right now. BARPART was the first organization in Bangladesh who took the initiative to run the maternal mortality survey for the first time, in Bangladesh. Probably it's in 1992, and they announced the result in 1993 or 94, or maybe in 90. I don't exactly remember. But from their survey, 5 things came out that these 5 things are pretty important. These 5 things are very much important. So you have to remember those 5 danger signs, because this was a national program and government took the initiative of safe motherhood in Bangladesh, because after the Kenya conference, the Nairobi conference, the whole world started working actively. So that's why Bangladesh also a part of it, and Bangladesh was also active. So vision, the convulsion, the APH, and the severe headache, these are all okay, and the edema. So we all these are danger signs of pregnancy. What is intranatal care? During delivery, and we know there are 3 stages of labor. So during these 3 stages, the support that we provide, the care that we provide is called intranatal care. And the aims, yeah, you can just, only for your understanding, you can go through it. But yeah, we want that the delivery should be in an aseptic way with minimum injury to the mother and the child. And we can be ready to deal with the complications such as the prolonged labor or antepartum hemorrhage, convulsion, malpresentation, or cord prolapse. Care of the delivery at the delivery time, resuscitation of the baby, care of the cord, care of the eyes, different cares. So these are all within the domain of intranatal care. Danger signs during delivery. Sluggish pain, just wait. Hey, yeah, Ahmed. Okay, sorry. So sluggish pain or no pain after rupture of the membranes, and good pains for an hour after rupture of the membranes, and cord prolapse, excessive bleeding during the labor, retained placenta, PPH, and collapse during the labor. So these are all very important. Okay, domiciliary care. This was the care given at home at some time, and it was given by usually in our village area, and also in urban area. There were the people who used to do this or used to provide the support for delivery. We call them DAI. Now we don't find, but still there are some in a rural area, but we provided the training to them. So they are called training DAI, but this is also local term, but the medical term or the public term for them is called TBA, trained birth attendant. And then after this, the Bangladesh developed into another stage. We call it SBA, skilled birth attendants. I don't know whether these things are in the book or not. But somehow I was involved in some development process of Bangladesh Health Service. That's why I do remember those things. I was working actively from 2000 to 2004. I worked actively with this reproductive health program in Bangladesh. Now, domiciliary midwifery services, usually they were trained about the mothers with normal obstetric history, but if there was any signs of complications, we have to refer to those cases. We have to refer those cases to the higher centers, either Upazila Health Complex or the district hospitals. and those with normal obstetric history, they could just deliver normally in the house. So it was showing no problems. The study showed no problems. So and mothers may be advised to conduct delivery at home by health worker or trained eye. Okay, so it was there before, and I told that now we don't call trained eye, we call TBA, trained birth attendants. And now the role of TBA has reduced very much, and now the role has been taken by the nurses. The nurses, they get training on obstetric care, and they are termed as SBA. The nurses who got the training of SBA, they can do normal delivery in the health complexes as well as in the rural areas. Advantage of these domiciliary services: mother delivered in the familiar surrounding, less chance of cross-infection, and mothers are able to keep an eye on her children and other domestic affairs. Disadvantage: mothers may have less nursing and medical care, may have less rest. She may resume her domestic duties too soon. Diet may be neglected. Now, the rooming in, what is it? The baby is crate by the side of the mother's bed, so that the mother, she can just get through to know with her baby, and then she can breastfeed the child, and it's just allays the fear of the mother about child nursing. Okay. KMC is the most promising way to save preterm and low birth weight babies in high and low income setting. Skin to skin contact on mother adequate. Really, I have no idea of this. Oh, yes, I think some of you helped me. Kangaroo mother care. Yes, so just to keep the baby as the kangaroo, like the kangaroo mothers. All right, it can be saving the babies from preterm and from low birth weight. And all right, so kangaroo mother care can prevent the infection, promote the breastfeeding, regulate the body's temperature, baby's temperature, regulate the breathing and brain activity, encourage the mother and baby bonding. And it was found, this is a study finding, that oops, worm chain. Okay. So the study finding is telling that it can reduce the newborn death by more than 50% or around half. Bangladesh, the kangaroo mother care was first introduced in 1990, and in 2007 the ICDDRB, they produced a setup. They have made a setup in Matlab in 2007, and in Dhaka Shishu Hospital it was set in 2013, and the first one, it was in Dinajpur. Now the postnatal care after delivery, objective is to prevent complications in this period, rapid restoration of the mother to optimum health, and check the adequacy of the breastfeeding, provide the family planning services, provide the basic health education. But the complications that commonly the mothers encounter after delivery: strombophlebotitis, puerperal sepsis, secondary hemorrhage, UTI, mastitis, but probably they missed. Yeah, they missed. All right. Another thing the mothers complain in the postpartum period, that they develop fistula, vesicovaginal fistula or rectovaginal fistula. So these are to complain that the mothers come up with complications, but it's not there. Strombophlebotitis, we have already talked about it. And this is the normal structure. And if there is a problem, then what happens? Those are below in the yellow color. Okay. The neonatal care, the cleaning of the airway, Apgar score, care of the cord, care of the eyes, skin, body temperature maintenance, and then the breastfeeding. Okay. The neonatal care. So it's what are the cares that we should provide? We have talked about it. Cleaning the airway, and so we have to clean the airway. Then the cord is should be cut, and then it should be clamped. And then the first 5 minutes, we have to check the respiration, and then the crying of the baby, the reflexes, irritability, pulse and heart rate, skin color of the body and the extremities, and the muscle tone. And care of the eyes to prevent ophthalmia neonatorum. So you see, this is the rule we have to follow. We have to clean from inside out. So we have to start from the inside, that is the from the medial part, and then we will have to go gradually cleaning up to the lateral side. So from inside out. Okay. Maintaining the body temperature, the baby should be wrapped up with a clean cloth, and of course the cloth should be non-irritable to the baby and easy, soothing. Care of the skin, the baby should take a bath within a proper interval. Maybe the doctors may recommend maybe every 2 days the baby should be given a bath. And then, yeah, these are the Apgar score, I guess. 0, 1, 2. So appearance, pulse, grimace, activity, respiration. Yes, these are the 5s. Okay. So if total score is 10, and 7 to 10 is no problem for the baby. 4 to 6 is there is a mild problem, and then 0 to 3 is a severe problem. And then we have to measure the birth weight, we have to measure the length, we have to measure the head circumference, and then the feeding to the patient. The colostrum is the first milk. It's given in high concentration of protein, because it comes from the mother and the first milk, and it comes with not only protein, also a good amount of nutrients, and then also rich in anti-infective factors. So that's why if the mother provides colostrum to the baby, it's natural way the baby should be protected with the immunity given from the mother. Take this colostrum contains this, and it prevents from diarrheal diseases as well as from respiratory tract infection. And the regular milk comes on the 3rd to 6th day after the birth, and the energy value is every 100 ml gives 70 kilocalorie of energy. Advantage is cheap, clean, hygienic, and available at correct temperature. It fully meets the nutritional requirements of the infants in the first 6 months of life. It contains antimicrobial factors, GIT and RTI, easily digested and utilized by both normal and preterm babies. And one thing you have to remember, probably when you will be doing your pediatric words, probably they will tell you, sometimes there is a bad practice in Bangladesh, mothers who really do not know properly how to breastfeed the babies properly. And what they do, that they just give the breast milk from one side, maybe within 5 minutes they change to the other side, and again 5 minutes. They think this is the way that the baby should get good nutrition, fresh nutrition, but this is completely wrong idea. Okay, the creator, he made it in such a beautiful and scientific way that it's completely amazing. So whenever the baby starts to take milk from the mother, the front part is usually liquid, and it contains some electrolytes, it contains sugar, so it increases the taste of the baby. So when the baby sucks the breast of the mother to take the milk, then the baby starts the taste of the sweet, because of the presence of sugar inside this breast milk and the other electrolytes. And then baby will start suckling more and more. And when the baby does it gradually, then from the behind, the main food parts, that is the food constituents, mainly the protein, the fat, and the carbohydrates, they gradually come out. So the ideal is the mother should complete one side first. And when the baby will have these proteins, the carbohydrates and the fats, the stomach will be filled up. Because initially the baby was interested, and then now the baby is getting the genuine nutrition as well as the energy. So the baby should feel satiety. The satiety center will be already completely satisfied, and then the baby will fall asleep completely. And then when again the baby will need, then the mother should change the side of the breastfeeding. But doing this 5 minutes from here, 5 minutes from there, it is pretty wrong. And these babies, they develop diarrhea because you are giving only the liquids and the electrolytes. So when there will be more concentration of the electrolytes, the baby should develop diarrhea. And we do not understand. The mothers, they don't understand. Oh, what had happened? I don't give anything to my child, but why there is diarrhea? So we need to understand the complete physiology and also the importance of giving the milk from one side first. And when the one side is completely finished, and then the mother should go to the other side. But by this time, one side is completed, the baby completes the sucking from one side, then the baby should automatically fall asleep. But if the baby is more thirsty, sometimes it happens, then the mother should change the side. All right. Yeah, helps in jaw development, prevent tendency to obesity, promotes the bondage and prolonging the period of infertility, and also family spacing. Advantage for mother, risk of PPH is reduced, and anemia boosts mother's immunity, delays next pregnancy, reduces the insulin of diabetic mothers, protect the mothers from ovarian and breast cancers and osteoporosis. At-risk infants are those low birth weights, the tweens, the birth order of 5, and furthermore, whatever. I have some reservations. Artificial feeding, because Some of you may also raise questions that birth order of 5 and more, if it is that much of a risk for the infants, why do we see that our grandfathers are 10 to 12 children, 10 to 12 brothers and sisters? So I don't know. And if they are given artificial feeding, if the weight is below 70%, and if there is protein energy malnutrition of the babies, as well as diarrhea. Low birth weight less than 2.5 kilogram in the first hour of life, and preterm baby and small for dates. Causes of low birth weights: malnutrition, severe anemia, multiple births, hypertension, acute infection, hard-working mother, and the placental causes are placental insufficiency and placental abnormality. Fatal causes are multiple pregnancy. Multiple pregnancy is not fetal cause. It means if the baby is the product of the higher serial, that is, if the baby is the 4th or 5th child, that is the problem. Fetal abnormalities, intrauterine infection, chromosomal abnormality. Since 1993, WHO started this baby-friendly hospital initiatives to improve the nutritional status of the young boys or girls and also the infants by promoting the breastfeeding. And the growth and development, no need to know the definitions. Determinants of growth and development, there are many different factors, no need. Physical growth, yes. How do we measure growth? These questions might be asked. So what are the important measurements? Weight for age, height for age, weight for height, head and chest circumference. And here you will find the application of your biostatistics. So what do we use? We use the Z-scores. Weight for age, Z-scores. Height for age, Z-scores. Weight for height, Z-scores. And then Z-scores within the 2 standard deviation plus and minus, we consider it as a normal. If it is less than 2, that means underdeveloped. The growth has not been achieved. If it is more, overdeveloped, obese. So these things are you need to go understand. What is Z-score, if you remember from the biostatistics class? Behavioral development, motor and personal, adaptive language. So all these development for this child. And then growth chart, very important. And it is also known as road to health chart. And in your exam hall or in your spotting, you will be given this growth chart, and then you will be asked or you will be given a specific point, and then you have to make your comment on that specific point. Maybe we will put a point at any one part of the growth chart, and then we will ask, tell me the growth of the baby, as well as tell me about the age or height of the baby and the weight of the baby as well. And then if we find that the baby's weight is within the road, because they have made it a road, we will go into detail. And so this was developed by one person, David Morley, and later WHO took it and modified. And then we can just look at it, and it will tell whether the baby's growth and development is going as planned or not. So you can see this. Sorry. So there are 2 black lines. The line below is the position of the 3rd percentile, and the line above is the 50th percentile. And then there are there should be another line. It is the just on the 97th percentile. So if the baby's growth is within this road, so now here is 3rd to 50th. If the baby's growth is within this road, within these lines, we tell that yes, the baby is developing as planned. But we can see that in the first year, the baby's growth was as planned, but we can see that in the 1 to 2 years, that is in the second year, there is a gradual decline of the growth of the baby, though it was within the planned road. But then we can see in the third year, this gradual declension has continued, and now in the third year, the baby has already developed, or the baby's position is not really as planned. That means he is suffering from problem. So you can see that we can tell that yes, the baby's growth has been faltered in the third year. So we have to be careful, because we will be giving you the chart, and there will be question in the spotting, as well as there will be question in the Viva exam, because in the exam we will just give this chart to you, and there is a line, but we will not put a line, we will put a dot. Okay, now the baby is at this point. Tell the age of the baby, tell the weight, and tell the height, like this. Okay, so these are the ways we have to really be careful. And you can also, when you go to the pediatric ward, you can just discuss with the teachers and then ask them how are they really measuring these growth chart to monitor the children's health. So there are this helps us to monitor growth, and it's also diagnostic, because we can diagnose whether the baby is really faltering or not. And if we find there is a faltering, we can make a plan what to do. And then it is also can be used as an educational tool. We can teach the mothers that yes, you have to remember these 2 lines. If the baby goes within these 2 lines, you can tell yes, the baby is within the planned way of development. Yeah, it also helps us evaluate, because we know we evaluated what happened in first year, what happened in second year, what happened in third year, and then it's a tool for teaching. So now you're learning about this growth chart. We can monitor, we can diagnose. Already we have talked about this, so we don't need to go into detail. Indicators of maternal and child care, the MMR, mortality in infancy and childhood, perinatal mortality, neonatal mortality, post-neonatal, infant, 1 to 4 year, under 5, child survival rate. These are only for short notes. It sometimes you might see in the written exam as a short note, so not more than this. And sometimes in the Viva interview exam, you might ask the definition of MMR, because MMR has got 2 definitions. So one is maternal mortality rate, another is maternal mortality ratio. So what is the difference between these 2? Sometimes you will be asked in your exam. Please be careful. MMR refers to 2 different things. One is maternal mortality rate, another is maternal mortality ratio. So these 2 have 2 different definitions. So you have to be careful, and then you have to learn these pretty well. Then important is perinatal mortality, neonatal mortality, and infant mortality. Oh, and under 5 mortality. Others not so. Short notes might be given: MMR, IMR, under 5 MR. These 3 are very important. You might be asked in the Viva as well as in the written. You will get it, but in the written you may get short notes for like this perinatal mortality also. Others just no need to. Maternal mortality, death of a woman while pregnant or within the 42 days of termination of pregnancy, irrespective of duration or site, from any cause related to or aggravated by the pregnancy or its management, not from any accidental or incidental cause. So every point you have to remember, and then we will have to go in detail, because you might be given tasks, or you might be given the calculations in your exam, and every point should be given probably in your exam. MMR, yeah, this is the definition of maternal mortality ratio. Okay, what is ratio? From your biostatistics knowledge or AP knowledge, what is ratio? কাকে বলে ratio?
দুটা জিনিসের অনুপাত বোঝায়।
দুটো জিনিসের অনুপাত, সেই দুটো জিনিস কি একই জিনিস?
Random.
The numerator is not the component of denominator.
এই হলো আসল, যে উপরে যেটা থাকবে নিচে সেটা থাকবে না। আমরা যখনই বলছি যে মেল টু ফিমেল রেশিও, বয় টু গার্ল রেশিও, তাহলে উপরে একটা আছে নিচে আরেকটা আছে, এইটা হচ্ছে রেশিও। ওকে, তাহলে এই জিনিসটা মাথায় রাখতে হবে। তাহলে ওখানে আমরা কেন ম্যাটারনাল মর্টালিটি রেশিও বললাম, ইনফ্যান্ট মর্টালিটি রেট বলছি, অথচ ম্যাটারনাল মর্টালিটি রেশিও কেন?
রেশিও কারণ 1000 লাইভ বার্থ চাইল্ডের ক্ষেত্রে স্যার
উপরে হচ্ছে ম্যাটারনাল ডেথ আর নিচে হচ্ছে লাইভ বার্থ। So you see, completely two different things. That's why it is ratio. But what is maternal mortality rate then? Maternal mortality rate then, what is the definition? Total opore jeta ache seta thiki thakbe, niche hocche total number of pregnancy during that year. ওই বছরে কতগুলো মা প্রেগন্যান্ট হয়েছিল, তাদের মধ্যে কতগুলো মারা গিয়েছে। তাহলে ওই সময়ের মধ্যে কতগুলো মা প্রেগন্যান্ট হয়ে ওই প্রেগন্যান্ট মায়েদের কতগুলো মারা গিয়েছে, that is called rate. If you remember, in rate the numerator is part of the denominator. Okay, so in the exam you might be asked about the differences of this MMR ratio and also MMR rate. আর এক্সটার্নাল যদি না জিজ্ঞেস করে আমি জিজ্ঞেস করব, কারণটা হচ্ছে যে এই প্রশ্নটা কেউ যদি পারে এক্সট্রা নাম্বার সে পাবে। সুতরাং যারা এক্সট্রা নাম্বার পেতে চাও তারা এটা মাথায় রাখবে। Alright. Causes of maternal mortality: postpartum hemorrhage, infection, prolonged or obstructed labor, eclampsia, abortion. Okay. Live birth, stillbirth, 1 kilogram birth, neonatal mortality, infant mortality. Okay. Causes of IMR: there are neonatal mortality and also there are post-neonatal mortality. So there are different causes. Important is low birth weight. Then yes, if there is any bad injury, sepsis, congenital anomalies, some, not all, hemolytic disease, the placental problem, diarrhea, ARI, tetanus. And also post-neonatal is the diarrhea. ARI actually it's not, is ARDS, you can tell. ARI is not that much within this neonatal period. Actually ARDS, acute respiratory distress syndrome. And then post-neonatal is ARI, correct? Diarrhea, ARI, malnutrition, accidents. But diarrhea, ARI, and malnutrition, these three are common. Others you don't need to. Okay. What is IMCI? Similarly, because gradually when we started taking care of the mothers, then we came to know, oh, there are some other services of the childhood illness. So one is the child may suffer from diarrhea, one is the child may suffer from malnutrition, another is the child may suffer from pneumonia. So different diseases. So the scientists, they again sat together and then they told that yes, all these are childhood illness. We shouldn't put it in a separate boxes and then separate people should be taken care of it. No, we should make this service as an integrated approach. So integrated management of childhood illness. So we took all the childhood illness in one component, and then we started providing support to this childhood illness. Okay. So these are all common childhood illness: diarrhea, ARI, malaria, measles, malnutrition. And what is this? A single diagnosis may or may not be possible or appropriate. Many sick children are not properly assessed, and the treatment, or what is TX? I have no idea. And parents are poorly advised. In response to these challenges, WHO and UNICEF develop a strategy known as IMCI. Okay, these are we talked about this. What is IMCI? So clinical guidelines designed for the management. No, we don't need to. Only one thing you have to know about this IMCI: what are the common diseases? This slide is important. Nothing else. You don't need to remember these. You don't need to remember these. No need. This is probably the ARI, yeah, or everything. All right. Yes. If fever, then what are the high risk malaria, low risk malaria? If there is measles, yeah, this is probably the WHO chart to assess the condition of the malaria from the baby. Again, this is for the diarrhea or dehydration. Okay, this is again the malnutrition, severe. Yeah, this is the malnutrition. This is the mastitis, acute ear. So this is the problem of the ear. But there is, I don't see any of this. Yeah. The important thing missing here is ARI. Okay, there is no assessment chart for ARI. We don't see. This is malaria, diarrhea, malnutrition, and ear infection. Okay, whatever. Okay, so we have finished this. Any question? If no question, we want to stop here. Yes, please.
স্যার আমি এক জায়গায় পড়েছিলাম ম্যাটারনাল মর্টালিটি রেট ইজ এ মিসনোমার, এই ব্যাপারে একটু বললে ভালো হতো।
আচ্ছা, ম্যাটারনাল মর্টালিটি রেট ইজ এ মিসনোমার, কথা তো এই জন্যই বললাম মিসনোমার। রেট শব্দটা আমরা বলছি, অনেক টিচার ভুল করে বলে ম্যাটারনাল মর্টালিটি রেট, কিন্তু যখন লেখার সময় দে রাইট উপরে ম্যাটারনাল ডেথ আর নিচে লাইভ বার্থ, তাহলে এটা তো রেট হলো না, এই জন্য মিসনোমার বলছেন। মিসনোমার হচ্ছে এই যে আমি যে গল্পটা করলাম, যে দুটো ভিন্ন ভিন্ন সংজ্ঞা, এইটা দিয়েই তোমরা বলবে যে when we talk about the rate, so তার মানে যখন এই কথাগুলো আসবে, you have to remember the core epi definitions of rate and also epi definitions of ratio. Rate, ratio, epidemiological terms. So what has happened, or what happens while we calculate the rates? The numerator is part of the denominator. So this is important. But here, the numerator is not part of denominator. Those two are completely different set. So why do we call it maternal mortality rate? So that's why it is a misnomer. But now, because of this misnomer, WHO has come up with another definition. Okay, commonly what we have called maternal mortality rate, let's term it its actual term, maternal mortality ratio. যদিও এখনো আমাদের বাংলাদেশে আমাদের টিচাররাও ওই ম্যাটারনাল মর্টালিটি রেট বলতে ওইটাই বোঝেন, যে মা মারা যাবে উপরে আর বাচ্চা জন্মাবে নিচে, এইভাবেই বসাবেন। ওকে, বাট এইটা হচ্ছে ম্যাটারনাল মর্টালিটি রেশিও। বাংলায় যদি কোনো মানে ব্যাখ্যা করতে কষ্ট হয়, ইফ ইউ ফিল প্রবলেম, দ্য গুড এক্সপ্লেনেশন ইন বাংলা ইজ, তোমাদেরকে বলতে হবে প্রতি 1000 বাচ্চা জন্ম দিতে যে যতগুলো মা মারা যায় এটাই হচ্ছে ম্যাটারনাল মর্টালিটি রেশিও। দ্যাটস ইট। প্রতি 1000 বাচ্চা জন্ম দিতে যে যতগুলো মা মারা যায় এটা হচ্ছে ম্যাটারনাল মর্টালিটি রেশিও। আর দেন হোয়াট ইজ ম্যাটারনাল মর্টালিটি রেট? ম্যাটারনাল মর্টালিটি রেট হচ্ছে যে একটা নির্দিষ্ট সময়ের মধ্যে যতগুলো মা প্রেগনেন্ট হয়েছে তাদের মধ্যে যারা প্রেগন্যান্সি রিলেটেড অবস্টেট্রিক রিলেটেড কমপ্লিকেশনসে মারা যাচ্ছে সেটা হচ্ছে ম্যাটারনাল মর্টালিটি রেট। ওকে, the mothers becoming pregnant and then out of them the mothers are dying due to pregnancy related cause is a ratio. Clear?
জি স্যার।
Okay, তাহলে আমরা এখানেই শেষ করছি। Thank you very much. Assalamu alaikum.